everyone. So my name is Dr. Darshini and I'm here with the second part of Autonomic Pharmacology, the cholinergic agents. So if you have not watched the video on cholinergic system, do watch it out as that will help you understanding this cholinergic agents better. So let's get started. So in the cholinergic system, as we all know, we had acetylcholine. That was the neurotransmitter there. Now, this acetylcholine helped in transmitting of the messages from one neuron to other, right? So this acetylcholine, like acetylcholine, we have other cholinergic agents also. Now, these cholinergic agents, they are also called as cholinomimetics because they mimic the pharmacological actions of acetylcholine. On the other hand, they are also called as parasympathomimetic. Why? Because they even mimic the activities or the pharmacological actions of that of parasympathetic nervous system. So acetylcholine, this is basically a quaternary ammonium compound, right? And as we all know, it is rapidly hydrolyzed by choline esterase, which are present in the neuromuscular junction. Now, because it is very fastly hydrolyzed by choline esterase, it has no therapeutic value. Okay? It has no therapeutic value or no therapeutic actions. Why? Because it is easily degraded or it is easily hydrolyzed by the pseudocholinesterase present in the blood. Now, even when if you give this IV in the blood, right? That means even if we give this acetylcholine IV in blood, there also it does not show a good pharmacological actions because of the presence of pseudocholinesterase in the blood. All right. Now, we have many other agents since the topic is cholinergic agents, right? So like that of acetylcholine, we have many other agents which have the actions which are similar to acetylcholine. So definitely we'll have a classification there which will help us understand this better. Okay, so in the classification, the cholinergic agents are of two types. First is the directly acting one. The second is the indirectly acting one. So in this video, we'll be mostly talking about the directly acting cholinesterase that includes choline esters and alkaloids. Now in choline esters, as we can see, we have acetylcholine, Bethanechol and Carbachol. So let's start with acetylcholine first, right? So acetylcholine, as we all got to know that it has muscarinic actions also and nicotinic actions also. Okay, so we'll be dealing one by one to both the actions. So first we have acetylcholine as the muscarinic action. So in muscarinic action, first we have is action on heart. Okay, so now in action of heart, this acetylcholine, the action of acetylcholine on heart, it is very well similar to vagal stimulation. Right? So what it does, it follows vagal stimulation, thereby stimulating the M2 receptor of the heart, as we all know. In the heart, we have the M2 receptors, muscarinic receptors of 5 types, M1, M2, M3, M4, M5. So out of that, the heart contains the M2 receptors. So this acetylcholine, what it does, it stimulates the M2 receptor of the heart, thereby it opens up the potassium channel. Okay, opening potassium channels. That results in hyperpolarization. That causes the hyperpolarization, right? And because of that, the SA and AV nodal activities are decreased. So this causes decrease in SA and AV nodal activities. right? So on the heart, it causes a vagal stimulation that causes the stimulation of M2 receptors which are present on the heart. Because of the stimulation of this M2 receptor, there is opening in the potassium channel. And as we all know, the opening of potassium channel causes hyperpolarization. Because of this, there is decrease in SA node and the AV node of the hearts, and overall if you see, then there will be a decreased heart rate, right? What all we can see, there will be a decreased heart rate. What else can we see? We can see that there is decreased force of contraction and there is decreased AV conduction, right? So these are the three things which is the overall effect of acetylcholine on heart, right? Let next see it on the blood vessels. So as we all know, on blood vessels, we have the M3 receptors present. Okay, so next one, the second one is the blood vessel. Right, so this acetylcholine stimulates the M3 receptors which are present on the endothelial cells, right? These which because of this stimulation, they release endothelium dependent relaxing factor, endothelium dependent relaxing factor, EDRF. Now, when this EDRF is released, it leads to vasodilation. And because of vasodilation, there is a fall of blood pressure. Okay, so this blood on the blood vessels, it causes this acetylcholine causes vasodilation because of release of endothelial dependent relaxing factor, and because of that there is a fall in the blood pressure. Okay, so first is heart, then the blood vessels. Next we come to few of the smooth muscles. That so in the smooth muscles, first one we'll have is the gastrointestinal tract, right? So now in gastrointestinal tract, what this acetylcholine, it combines with the M3 receptors, right, of the gastrointestinal tract. So GI tract. So in this tract, what it does, it increases the tone of gut. It increases the tone of gut. Because of that, there is increase in even peristaltic movement. And because of that, even there is increase in GI secretions, right? Because of that, there is a release in the sphincter. It may also cause defecation, right? So mostly in GIT, it increases all the peristaltic movement and all of the secretion, right? Next come the effect of acetylcholine on urinary bladder. Okay, so now in urinary bladder, what it does, there are M3 receptors present on the urinary bladder. So it stimulates the M3 receptors and it causes urination. Right, so urinary bladder, it reacts or it combines with the M3 receptor and there it causes urination. Next, we'll see the effect of acetylcholine on are bronchi. Okay, so as we have M3 receptors present on the bronchi, so it contracts the bronchial smooth muscle. So when it contracts on the bronchi, what it does, it contracts the smooth muscles. Thereby it causes bronchospasm. Right? Therefore, these cholinergic drugs are contraindicated in asthma. Right? Why? Because it contracts the smooth muscles, thereby leading to bronchospasm, and it also increases the tracheobronchial secretions also. So because of all of these acetylcholines are actually contraindicated in asthma. Okay, next after that, let's see its effect on the exocrine glands. So let's have, suppose this is a exocrine gland. Now, on the exocrine gland, it produces increase in salivatory secretions, lacrimal secretions, sweat, bronchial and gastric and other GI secretions. So basically, it will increase all the secretions of the exocrine gland, right? So we can write it over here that it increases salivary, lacrimal, bronchial, gastric, and all the other GI secretions. Clear? Okay. After this, we have the next is eye. So on eye, basically, it does not have a lot of pharmacological action because of its poor penetration. This acetylcholine is because of its topical administration and because of its poor penetration through the tissue, it does not produces any any pharmacological actions on eye. Okay, then these were all the muscarinic action. Now let's come to the nicotinic actions of the acetylcholine. So in nicotinic action, we have three types of actions. First is action on the autonomic ganglion. Second is the action on the skeleton muscles. And third is the action of central nervous system, right? So let's see first its action on the autonomic ganglion. So on a higher dose, it produces dangerous muscarinic effect, okay? It produces dangerous muscarinic effect, especially on the heart. So hence, before the administration of this acetylcholine, it is important to give atropine. Now, atropine, it has action which is opposite to that of acetylcholine. So if acetylcholine is cholinergic drug, so atropine will be an anticholinergic drugs, which we'll be learning in the next videos. Okay, so the higher dose of acetylcholine, it stimulates both sympathetic and parasympathetic ganglion, causes tachycardia as well as rise in BP. So it is a bit dangerous. Then on the skeleton muscles, at higher concentrations of this acetylcholine, it causes twitching. Okay, twitching of the muscles that even is that is followed by prolonged depolarization of the neuromuscular junction, and even it can cause paralysis. Okay, now its action on central nervous system. Now, even when you give it intravenously, it does not causes any central effect because of its poor penetration in the blood-brain barrier, right? It has poor penetration on the blood-brain barrier. So because of this, it does not produces any central effect. Okay, so that was all about acetylcholine. After acetylcholine, we have Bethanechol. So in Bethanechol also, it has selective muscarinic actions on GIT and urinary bladder. And because of that, it is preferred in post-operative urinary retention. Okay, next we have, so that was all about acetylcholine and Bethanechol. Next, we have Cholinomimetics alkaloids. So esters are done. Now let's come to alkaloids. So in alkaloids, we have three of them. So pilocarpine. So first we'll be learning about what is pilocarpine. Okay. Bethanechol, as we got that it is used in post-operative urinary retention. Now this alkaloids, we have three types: pilocarpine, muscarinic, and nicotinic. Sorry, pilocarpine, muscarinic, and arecoline. These are the three alkaloids. So first, let's say about pilocarpine. So pilocarpine is a cholinomimetics alkaloid. As we all know, we are reading cholinomimetic drugs. So it is a cholinomimetic alkaloid that is obtained from Pilocarpus plant. Okay. It is obtained from Pilocarpus plant and it is a tertiary amine. So it produces muscarinic as well as nicotinic effects by directly interacting with its receptor. Now it has mostly, predominantly there is muscarinic action, especially on all of the secretory activity. Now let's see the uses. What all uses are there for pilocarpine? So first use will be it is used in acute angle glaucoma. Right? It is used topically for glaucoma. Okay. Next, it is used in mydriatics. So in mydriatic, it basically breaks the adhesion between iris and the lens, right? Third, we have it is used to reverse the pupillary dilation. So we can write it as reverse. It reverses pupillary dilation. Okay, and lastly, it is also used, let's say, if there is some dryness of mouth, right? So it is used in dryness of mouth. Why? Because it increases the salivation. Now, because of these are the uses, that is where it has the pharmacological action. So if we understand the uses, we can just find out what could be the adverse effect. What are the possible adverse effect for this? Adverse effect includes the first adverse effect which I can guess of is salivation. It can cause excess salivation because it helps in secretion of more of the all the secretory fluids, right? Salivations or excessive sweating, or it can even cause bradycardia. It can cause diarrhea because of increased GI secretions and increase of the peristaltic movement. Then after diarrhea, on the lungs, it causes bronchospasm because of it stimulates or it causes lots of secretory actions. So it can cause bronchospasm. We have already learned that it is used as a contraindication in asthma, right? So it is bronchospasm. Bronchospasm. Okay, and also in pulmonary edema. So these can be the adverse effect. Okay, so now this is pilocarpine. So after pilocarpine, we'll be learning about muscarine. Now in muscarine, it is a most common ingredient of mushroom poisoning. So mushroom is very commonly available, right? So most common ingredient for this mushroom poisoning is muscarine. So it is mostly causes mushroom poisoning. All right, so now this mushroom poisoning is actually classified into 3 types. One is the rapid onset, second is the hallucination type, and the third one is the delayed onset. Now, this rapid onset, it is actually caused by inocybe species. The hallucination type, it is caused by Emantia muscarinus. Emantia muscaria. And the last one, the delayed onset, it is caused by Emantia phalloides. Okay, Emantia phalloides. Now, the rapid onset, it is characterized by excessive muscarinic effects that will cause vomiting, diarrhea, bradycardia, or salivation, or sweating, or bronchospasm, and even hypotension because of the toxic muscarine, all the effects on muscarinic action. So, how will it respond? It responds to atropine. That means atropine is the drug of choice over here. Right. The second one, the hallucination type. So here the toxins are mostly, the toxin is mucinol. So it mostly produces the central effect, right? And it does not has any specific antidote. And moreover, this atropine is contraindicated here. So you can just give few of the supportive treatment in hallucination type. Okay. Then third one is the delayed onset type. So here the toxin is amatoxin. Okay, so now it results in delayed gastroenteritis and hepatic and all the renal damages. Now it does not respond to atropine, and it is to be treated with thiatic acid. So this thiatic acid is the drug of choice. Here also it does not respond to atropine, but atropine is not contraindicated. In hallucination type, atropine is contraindicated. So mostly the supportive care should be given in mushroom poisoning. Okay. After that, next similar to this muscarine, the last one is Arecoline. Now, Arecoline is an alkaloid that is obtained from Arecoline. Okay, and it has muscarinic and nicotinic action, all which will be similar to choline esters, which was the acetylcholine, right? So basically, if we understand one of the prototype of the drug, it is usually easy for us to understand the classification. So in this classification, we have covered all the directly acting drugs that are choline esters and alkaloids. So choline esters included acetylcholine, Bethanechol, and Carbachol. Alkaloids included Pilocarpine, Muscarine, and we even learned about Arecoline. Right? So in this video, till here we have completed. Next video will be continuing with indirectly acting cholinergic agents. So that's it. See you in next video.